Kristen here at UT Southwestern Medical Center. Thank you for joining our Facebook Live chat on Hypertrophic Cardiomyopathy, or HCM. We're really thrilled to be joined by two of our best UT Southwestern cardiologists. You have Dr. Aslan Schreier and you have Dr. Mark Link. So, as always, remember that we want you to like and share this conversation and ask as many questions as you can or that you have. We can't comment on specific patient issues, but we can definitely speak in generalities. So now's a great time to start submitting those questions. Definitely also want to thank the American Hypertrophic Cardiomyopathy Association for their support of this chat. So thank you both for joining us. I know that before we get started, we do have a conference coming up next weekend that is for patients, or they can come register. Can one of you tell us a little bit about the conference and what they can expect to hear there?
Yeah, so we have a conference, like you said, on the 22nd over at Clements.
Okay.
And it's really geared towards patients with hypertrophic cardiomyopathy and their families, or people who are just interested in learning more. And there'll be several of us, many people who are from our center here to discuss various aspects about the condition, including treatment options, arrhythmias, exercise, genetics, all those things that patients really want to know about. So we're excited about this.
Yeah, we're very excited. It's a great patient conference. There's 20 to 30 minute talks on many of these aspects that patients really want in-depth information on.
Okay, sounds good. So what we're going to do is we're going to share a link to where you can register for the conference, and then we'll go on and get into our questions. So just to get us started, what is hypertrophic cardiomyopathy and why is it so dangerous? You want to start, Dr. Schreier?
Sure. Hypertrophic cardiomyopathy is hypertrophic just means excessive growth, and cardiomyopathy generically means that there's something abnormal with the heart muscle. So it's a condition where the heart muscle grows thicker than normal. It's often genetic, running in families. And it can be, most of the time, or oftentimes, it's asymptomatic, but it can be something dangerous or can impact patient's life if the muscle gets thick enough that it impairs the ability of the heart to contract, or there's obstruction or thickened heart muscle that keeps blood from coming out of the ventricle normally. And it can predispose patients to get arrhythmias, which can be atrial fibrillation, or can be other life-threatening arrhythmias. So it can have a wide range of effects.
So Dr. Link, how is HCM diagnosed?
So it can be diagnosed in a number of different ways. First of all, patients can present with symptoms such as palpitations, such as chest pain, shortness of breath. You can present when you show up to your doctor and get an EKG without symptoms and your EKG is abnormal. And that's part of this screening debate that's ongoing for kids. Is it worthwhile doing an EKG to try to find those kids with HCM? And then it can present with the arrhythmias, with AFib or sudden cardiac death.
So is this something that somebody could be, I understand there's a genetic component. Is it completely genetic?
Yeah, it's thought to be completely genetic. In 2/3 of the patients, if you do gene testing, they're positive. And it certainly runs in families. But there are other times when it shows up for the first time, maybe a new genetic abnormality. So we're learning a lot about genetics. It's present in about 1 in 500 patients in the United States, people in the United States, and that appears to be similar worldwide.
Right. So is HCM something, can it be cured? Is it something that your average person, that 1 in 500, needs to worry about? You take that one, Dr. Schreier?
In terms of it being cured, not with current sort of technologies. We're trying to learn more about whether the expression of these genes can be delayed or altered in some ways. And then in terms of the second part of the question, yeah, it is something that we do generally need to know about, just because for some patients, again, the majority may be asymptomatic their whole life, but for some patients, they are at risk for complications from the condition, so we need to know about that.
And we're going to answer something about the cure too, because very few conditions in medicine are actually cured.
Right.
But they have to be managed. And that's very true of hypertrophic cardiomyopathy. You don't cure the disease at the current time. It may be true in the future. But you still need to manage the patients. And the management of patients dramatically affects their quality of life and even their longevity.
Right. That actually is a perfect tie-in because we've started getting some questions in. One of these questions came from Andy Marie, and she asks, how does HCM affect a person's daily lifestyle? That sounds like a great question for you to start with.
Well, many HCM patients are completely asymptomatic, so
Right.
it doesn't even affect their daily lifestyle. For other HCM patients, they can have dramatic symptoms and they can have miserable quality of life, including chest pains and shortness of breath and arrhythmias. And those are the ones that need more intensive management. But the key is we have treatment techniques that we didn't have 20, 30 years ago. So we have excellent treatment for HCM patients.
Let's talk a bit about some of those treatments. And I know I see a question in here for Tracy, but I want to stay on this for a second. What are some of the options now that patients who deal with HCM have available to them? Dr. Trier?
Well, for the asymptomatic patient, we generally don't do anything. For the patients who are symptomatic, the majority of them can be managed with some medicines like beta blockers like metoprolol many patients are on, or calcium channel blockers, and there's some additional medications. Some patients have arrhythmia issues, and Mark can speak to that in terms of how that's treated. For some patients who have obstruction, which is a subset of the patients with hypertrophic cardiomyopathy where the muscle is thick and it's hard for the heart to pump the blood out because of the muscle essentially keeping the flow, impairing the blood flow out of the heart, we can either generally have the surgeons cut that out, or for patients who are high risk for surgery, we can do some additional procedures to reduce that muscle thickness, and that will help a lot of the patients feel better. So those are the surgical, and there's research studies too that are ongoing.
Okay, sounds good.
I'll focus on the arrhythmia aspects. So in terms of sudden death, for every patient, whether symptomatic or not, we want to work them up to see what their risk for sudden death is. There are 5 accepted risk factors, and there's more emerging risk factors. And for patients without any risk factors for sudden death, they should be very comforted that they don't need an ICD, and they shouldn't worry so much about sudden death.
Gotcha.
And the other aspects of the treatment are AFib. AFib can be actually very difficult to treat in patients with HCM. They really don't like being in AFib. They get markedly symptomatic. And we have treatments like antiarrhythmic drugs and ablations for patients with AFib also. So we really do have good treatment. For those patients that are at risk of sudden death, it's defibrillators. And for AFib, it's medicines and ablations.
So there are good ways, it sounds like there are some really good ways to help manage this if you do have symptoms.
Yes.
Okay, good to know. So this is actually, we have a question here from Tracy Drain, and her question is there any new research on the genetic aspect of HCM, especially for those of us who don't have the common gene? Whoever wants to start with this one.
Unfortunately, not that I'm aware of. There are, like Tracy's alluding to, there are all comers probably it's 50-50 whether we have a gene mutation that we can associate with the condition. So so that means that about half the time that we do genetics and the patient with hypertrophic cardiomyopathy come up with no accepted gene that has a mutation that predisposes that condition. Now, there are times, and this is not uncommon, where the genetic testing that we do comes back negative, i.e. that there's no known mutation that has caused this. Now, that is constantly being annotated so that, in effect, that the companies who are doing the testing will initially say, well, we don't know that this mutation has caused this, but as they get more people who have had that mutation, then they will often bump up those gene mutations. And so sometimes for patients who have a mutation in a gene that we're not really sure about, then we can sort of, after a year or two, then ask the company to update it to see whether that mutation is actually causal or not. So, but unfortunately, there are a block of people who just don't have a gene mutation to correlate with their cardiomyopathy. And that is a problem for screening. It means that we can't use that genetic information to screen family members.
Okay.
But the prognosis seems to be similar whether you're gene positive or gene negative, so we really use the genetics more for ease of screening family members than to make a lot of treatment decisions on.
Okay, good to know. Great question, Tracy. So there was a question that came in ahead from Kristen Arachiga, and I want to start with you on this one, Dr. Link. She's wondering, actually, excuse me, this is from Heidi. She's hoping to find out more about exercise limitations with LBBB post-myectomy. I mean, what sort of restrictions would somebody with that have that procedure be looking at?
Well, let me actually broaden that for exercise in hypertrophic cardiomyopathy, because there's no real difference for a left bundle, not left bundle, pre-myectomy, post-myectomy. So there really isn't any difference for exercise restrictions. You know, early on, 50 years ago, there was an association of hypertrophic cardiomyopathy and sudden death during exercise. And so that has made us in the cardiac community fearful of exercise in HCM. And that has led to exercise restriction for competitive sports in a number of the guideline statements over the last 20 years. However, what we're learning more and more about hypertrophic cardiomyopathy is maybe exercise isn't so bad. And there was a study that was published last year out of the University of Michigan that was looking at moderate intensity exercise in patients with HCM. And those patients that had moderate intensity exercise actually improved in their capacity to exercise, while those patients who didn't exercise didn't improve. And it was safe. There wasn't any sudden death or arrhythmias. Interesting. And we actually have an ongoing study here looking now at high intensity exercise in hypertrophic cardiomyopathy patients. So if moderate intensity exercise is potentially beneficial, how would high intensity exercise be? And I wouldn't encourage high intensity exercise at the current time because we still don't know whether it's safe. But we have a lot to learn about exercise. And I think a very useful tool to kind of gauge how much exercise a hypertrophic cardiomyopathy patient can get is they have to be able to converse while they're exercising. I think if that's a key factor. So you have to be able to converse in a normal voice when you're exercising, and if you go above that threshold, you should back off.
Well, that's what I've heard of that anybody should be able to do when they're exercising. So it sounds very similar to what you would give a person without this. Am I hearing that correctly?
No, there's evidence that high intensity exercise is better than moderate for people without heart disease. That it's better in preventing coronary disease, it's better in fitness. And it's not dangerous. But again, for hypertrophic cardiomyopathy, there's still a concern that high intensity exercise is dangerous. So I wouldn't advocate high intensity exercise at this time.
Okay. Do you want to add anything, Dr. Truer?
Also, particularly for patients who are obstructive, there are some other just practical things that we have them avoid, like a lot of weightlifting and other things where they may be bearing down because that seems to increase their left ventricular outflow tract gradient. A lot of patients are familiar with the term, but that can predispose them to get lightheaded and potentially pass out. So there's some practical things that we talk about in the clinic in terms of those activities, but echoing what Mark said, the left bundle branch block, which is commonly seen after myectomy, shouldn't in itself alter recommendations for exercise.
Okay. Well, we had a follow-up question, and this one is from Jamie. And Jamie, I'm not going to read your entire. You provided a lot of medical information. I'm not going to read that. But her baseline question was, she's dealing with HCM, and she tries to get her heart rate between like 100 and 125 for a cardiovascular workout. Is wondering what's a good and safe heart rate to stay with when you're exercising if you do have HCM, or if you're dealing with it.
Yeah, I think it's important to emphasize that heart rate is correlating with exercise. But for patients on beta blockers or verapamil, it doesn't correlate with exercise, and a lot of hypertrophic cardiomyopathy patients are on these drugs that inhibit your ability to raise your heart rate. So if you're on one of those drugs, I wouldn't use heart rate. And what we like to use is really kind of a perceived exertional scale. You can think what 100% flat out exercising would be. We don't like you to go above 80-85%. So you can use the heart rate as sort of that guide also, but it's probably not as accurate as the perceived exertional scale. So 80-85% of what you think would be all out.
Okay. Great question. Thanks for asking it. So what types of physical activity are beneficial for individuals that are dealing with symptomatic HCM? You want to start, Dr. Trier?
Well, again, that's kind of a moving target, like we talked about, in terms of the magnitude of the activity. You know, I guess generally speaking, I think cardio is a good activity for patients to do. I usually discourage them from doing a lot of heavy weightlifting. The other thing I just, you know, in the absence of a lot of data, ask patients not to do is a lot of sort of CrossFit activity where they're going from 0 to 60, you know, within a very short period of time until we know that those kinds of activities are safe.
Okay.
I don't know if you have additional.
Yeah, very, very similar things. I mean, avoid, you know, heavy weightlifting. Toning lifting is fine, but heavy weightlifting I would avoid.
Okay.
And then, again, the high intensity exercise routines I would still avoid at this point.
Okay, good to know.
There are some other activities, I don't know how we don't necessarily regard them as you know, exercise or sports per se, but you know, for patients who are, you know, who are swimming or who are, you know, diving or skydiving, those other activities, they're you know, we don't necessarily encourage those things, but it's important, I think, when patients do have hypertrophic cardiomyopathy in there, that they have people around them to, if there is an issue, that there's somebody around. So yeah, there's just not a lot of data on what to do in those patients, but for people who do end up doing those activities, I emphasize that in the very uncommon chance that something happens, it's important to have people around.
Okay, good to know. So we've got a question here from Lonnie, and Lonnie lost a son, 25-year-old son, 11 years ago to diagnose HCM after septal ablutions, a defibrillator pacemaker, apparently went into cardiac arrest numerous times, and I'm sorry to hear this about your son. You know, we can't answer a specific question. They're asking about a specific medication, but you know, when somebody is going into cardiac arrest and you know that they have HCM, kind of what would you typically do? I mean, is there a common path that you would take as a physician to address that?
Yeah, the ideal goal is to identify the patients that are at risk for sudden cardiac death and get them outfitted with a defibrillator. And that's an important part of the HCM Center and of the physicians there as we go through the screening for HCM, sudden cardiac death. In the event that sudden cardiac death occurs in anybody, including those with hypertrophic cardiomyopathy, it's important to provide high-quality CPR and defibrillate as soon as possible.
Okay.
Those are the two things that are going to save lives when people have a cardiac arrest, and call 911. But it's high-quality CPR and AEDs defibrillation.
Okay. Okay. So we have a question in here from Crystal, and this came up ahead of time, but it's an interesting one. Are there major differences in the treatment of valve disorders versus HCM? You want to take that one, Dr. Trier?
Yeah, I'd say, you know, there are significant differences. You know, it depends on sort of which valve that we're talking about. The mitral valve, that's the valve that lets the blood essentially come out of the lungs into the heart. That is involved with hypertrophic cardiomyopathy. Sometimes it's a little leaky as part of secondarily as part of the mechanism of outflow tract obstruction. That is usually fixed with myectomy. That usually fixes that part of the leaking valve there. But if in case it's a primary issue with the valve, that just has to be fixed with surgery. The aortic valve can act a lot like hypertrophic cardiomyopathy, and in fact, in the days before hypertrophic cardiomyopathy was really ironed out as a disorder, patients would sometimes go to the operating room for the aortic valve to get fixed, only to find that the aortic valve was normal before we had the current technologies and understanding of what this was. That is a fixed obstruction, so aortic stenosis, the valve is just blocked all the time. And in hypertrophic cardiomyopathy, it's a dynamic obstruction. It occurs in parts, in only parts of the cardiac cycle when the heart's squeezing, and it varies from day to day and from activity level, and it varies if you're on medicines or not. And that's not the same as the fixed obstruction that we see in an aortic valve disease. And that aortic valve disease needs to be treated surgically when it becomes symptomatic, versus
for the question, Crystal. Here's one from Carter, and Dr. Link, we start with you. At what age are patients most likely to be diagnosed with aging, with this?
Yeah, so typically, I mean, you're born with the gene, so, you know, but it doesn't come out phenotypically or doesn't show up on an EKG or an echo until typically adolescence.
Okay.
So around the time of puberty, when all of your body is growing, is when you'll typically start to show up.
Okay. All right, here's another question, and these are great questions, keep them coming. Here's one from Jamie. You want to start with this one, Dr. Trier? Her question is, if your child carries the same gene mutation connected to an HCM, how often should they be checked? Is there a common age it kicks in, or should it be checked at all?
Well, sort of like the last question, it, you know, like anything, it's, well, there's a bell-shaped curve, and it seems to be the highest incidence of us picking it up is in puberty. So we usually, I tell patients that once the child sort of hits their double digits, we should start screening them every year with echocardiograms to see how the ventricle's getting thick. Now in this case, it sounds like the gene is positive, so we know that at some point it's likely that the child will develop hypertrophic cardiomyopathy. So it's kind of like to just figure out when all that is occurring.
Okay.
And so once they kind of get to the early 20s, they can cut back on their screening to every few years after that. But typically, like Mark said, we would expect that the hypertrophy occurs during adolescence. So we kind of hammer screen in that period to try to pick it up early. And that's similar to if the gene was negative, we would still recommend that. And if Jane in this case had no gene mutation, then we would still recommend her kids get screened in that interval.
Okay. In adolescence, are we talking kind of 10 to 20, a little later, a little earlier?
Yeah, I think the guidelines say 11, but
okay.
I just make it easy for the families to say once they hit sort of double digits to get that done.
Okay.
There's no strict screening suggestion in kids who are younger than that, unless the family prefers that, or there's there's a sporting requirement that happens. But in general, around double digits is when we have to get screened.
Okay. So here's a question from Kristen, and it is migraines and HCM. Is there a connection? Either one, you want to take that one?
Yeah. There's no definitive evidence, but there appears to be a connection between migraines and HCM. We see it a lot in HCM patients, but there's no clear mechanism to explain it at this point, but there may very well be a connection.
Okay, good question. So we're getting near the end of time. We've only got about 5 minutes left, so if you have a question, please submit it now. I know one of the things we've talked about a lot is kind of the importance of getting screened if you do have this gene, even if you don't. I mean, what is the best case scenario in terms of screening it? At what age is the best time? We're talking about 11 and 12.
Yeah, so I think in general, if there's a family history of hypertrophic cardiomyopathy, we really encourage those kids who are at risk in their teenage years to get screened. And I think we do see more of it then. Maybe as there's a growth trigger to get bigger, and so we see that kind of go a little haywire in patients who are predisposed. So maybe that's what we see more often. But there's also it's a higher risk period for sudden death at that time, and it's also it's just psychologically a more devastating thing when a young adult or child dies from this condition. So I think that plays into why we kind of really encourage screening at that age.
Okay.
And then younger than that, they may not have any evidence of it, and it is. We also don't want to, psychologically, cripple the family to believing they need to get the kids screened, every 6 something like that. So we kind of wait till there's a high likelihood that they have it and are seemingly at higher risk.
Okay.
I want to add one comment to that, because this is where genetic testing is very useful. This is probably the biggest use. If the parent has a positive gene for hypertrophic cardiomyopathy and the kid does not have that same gene, they don't have it.
Okay.
And you don't need to screen them when that goes.
Oh, wow.
So that's where genetic testing comes, in my mind, particularly useful.
Okay, great question. Thanks for asking it. Those last minute questions are coming in. This is one from Laura Wells. And what are the ECG changes you will see to detect HCM? Is that something you can explain kind of simply?
Yeah, simply it's a bizarre and unexplained EKG pattern.
Okay.
That just, it's not normal. It's not specific to HCM because there are other conditions that can cause these bizarre EKG patterns. So, but what we do know is if you do have a bizarre EKG pattern, you should be evaluated.
Okay. All right, I think we've got time for maybe 2 more questions. Here's one from Cece. Her question, are there any new, and we touched about this earlier, are there any new breakthroughs in HCM treatments? You mentioned several surgical options. Any others that are on the horizon?
Well, we don't know, the effectiveness of some of these things. So we're studying, for example, the impact of exercise to mitigate things. There's some trials looking at whether specific medications that are already used on the market may impact the thickness of the ventricle. Mavacamten is another drug that we're part of a multinational study looking at whether it can impact symptoms of hypertrophic cardiomyopathy. So there are some therapeutic options on the horizon. In addition to other genetic, gene therapies which may be floating around, but clearly far off from clinical use now.
So what advice do you give to patients who have come in, they've gone through testing, you've just determined that yes, you have HCM? What do you tell them? You gonna start, Dr. Link?
Sure. First of all, HCM is compatible with a long and healthy life. I think that's something that a lot of people think once they've been diagnosed with a cardiac disease that the end is just near. So that's the first thing to understand. It's really compatible with long and healthy lives. Second, that we do have good treatment for HCM. We have treatment for the arrhythmias, we have treatment for sudden death, we have treatment for the symptoms. So there are good treatment strategies out there. And so it's not a deadly, disease that's going to kill you. It really needs to be assessed and treated, but it is compatible with a long, healthy life.
Sounds like good news. Do you have anything to add, Dr. Terrell?
Yeah, I guess I'd echo that sometimes our role is, and I don't know whether this is what the providers say or what the patient hears as their first reaction, I'm not sure, but often our job is to sort of like take it down a notch from the initial diagnosis or what the patients have been told. They're really, maybe it has to do with looking things up on the internet and whatever that they've read, and we kind of have to sit down and have the discussion that, well, yeah, you can plan on being 87, kind of thing, and you don't need to avoid everything that you were kind of told. There are certain limitations that you have to have. So a lot of it is about, talking everybody off the ledge that we've kind of come to, and I think that's the benefit of going to an HCM center where we see more of it, and we kind of help patients in that way.
Yes, and we've shared some information in our comments about that UT Southwestern is an HCM center, kind of what that means. So we'd encourage our visitors to go look at that. We also have the conference coming up next weekend. We've got one final minute. We're going to mention that. It's next Saturday. It starts at 8 a.m. It's going to be at Clements University Hospital. Dr. Leek and Dr. Terrell are both going to be presenting. Is that correct?
That's correct.
Absolutely. So it's open to patients. It's open to members of the community. It's open to caregivers. We'd encourage everybody to go. Anything you want to add to that?
No, I think it's a great lineup of talks that I'm actually looking forward to hearing. So it's been a great group of people, and we look forward to it.
Awesome. Well, I think that's all the time we have today. I want to thank you both for joining us. I think we've gotten some great questions and great guests. You know, we're going to wrap up now. Don't forget, this will be on our Facebook page here, so if you have friends and loved ones who weren't able to watch it, they can come back and watch it, so please share. It'll also be on our YouTube channel. And in the meantime, I hope you tune back in next week. We're going to be talking about prostate cancer and a clinical trial that's underway here at UT Southwestern. So thank you for joining us.